and good evening, everyone. Welcome to our 117th Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by bluehealthethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Iheno Tadele, a general physician from Blue Hills, Ethiopia, today's host. So it's a pleasure to have Dr. Tizazu Kebede here with us to have a presentation on the principles of vascular trauma management. So for those of you who don't know Dr. Tizazu Kebede is an assistant professor of surgery. He is a general and vascular surgeon at Alert Hospital.
Okay, thank you very much for this opportunity. So on today's webinar, we would like to discuss on the principles of vascular trauma management. As you know, the management of vascular trauma is relatively a newer subspecialty in our setup. For the past a couple of years, there are trainees on vascular surgery. So I would like to give you some principles on vascular trauma management. I know that the detailed vascular trauma management might be extensive, but at least knowing how these vascular trauma patients will be managed in principles would be nice. So these are my outline. I will start in giving you some introduction regarding vascular trauma, and we'll see the evolution of vascular trauma management. Especially vascular trauma is mainly, its evolution is mainly related with war. So we will start from World War I and II, and subsequently we'll see each of the war, how they advanced the vascular trauma management. And I will give you just a highlight on vascular injury classification and the scoring. And we will focus mainly on pre-hospital management and on emergency department reception of those patients who are managed during pre-hospital. And finally, we will see the diagnosis of vascular injury and the principle of definitive management. So, on introduction, the vascular injury is a major cause of both death and disability in worldwide, not only in our setup, like in low middle income country, even in the high income countries, vascular injury is a major cause of death and disability. And the mortality from trauma it's a complex thing, but hemorrhage is the main cause of death. So to mitigate or to minimize the mortality which occurs because of the extensive hemorrhage, three main things should be done. And the first one is a rapid transportation of patient from the scene to the hospital. And a point of injury hemorrhage control is also a major part, and the third major principle in the management or in the avoidance of mortality from trauma is early operative intervention. So for those patients who passed this extensive injury, they might have a long-term disability from either limb loss, chronic pain, or they might have also post-traumatic stress disorder. So the evolution of vascular trauma management, it is mainly related with war which occurs in the world. So the First World War and the Second World War has taught us the ligation of vessels. So the main management during these two world war were ligation of vessel. In the case of Korean War, it has taught us a lot. And the first thing is there is an improved evacuation of a patient from the trauma site. And the other is there is an early reconstruction strategies like primary repair or anastomosis or even interposition grafts were tried during this Korean War. But in this Korean War, there is a significant time delay of transportation of the patient, plus there is also a delay in resuscitation requirements. In the case of Vietnam War, the major thing that we learned during the Vietnam War is creation of a vascular registry, and this registry has provided vascular surgeons to characterize the injury pattern and also the outcomes following each intervention. The nearest or the recent war in Iraq and Afghanistan, they are considered as a global war on terror, and this global war on terror has educated vascular surgeons a lot. And the first thing is, in this war there is a high reduction in death rate from a potentially survivor vascular injuries, plus there is also an improved quality of functional extremity salvage in this war. The main reason behind this reduced deaths and the improved quality of functional extremity salvage is the use of early tourniquet application. Plus, there is also a limited tourniquet duration. So this limited tourniquet duration has increased the effectiveness of the tourniquet, plus it also reduced the associated complications. But despite this improvement in this global war on terror, during this Iraq and Afghanistan war, there was an increased incidence of vascular ligation due to the mechanism of injuries. The mechanism of injuries has the extent of injury has increased in this war, so there was an increased incidence of vascular ligation. Besides this global war on terror has also taught us application of surgical adjuncts like temporary vascular shunts, and these temporary vascular shunts were used at the sites, and they were useful to facilitate a delayed definitive vascular repair. Plus, there is also a routine performance of fasciotomies. This routine performance of fasciotomies has minimized the incidence of undiagnosed compartment syndrome. Beside these surgical adjuncts, there is also progress in the management of both complex vascular injury patterns plus complex soft tissue wounds. And those complex soft tissue wounds were being managed by closed negative pressure wound therapy, and this has greatly improved the outcome. And the new thing in this global war on terror is the application of endovascular techniques. And these techniques were helpful both in diagnosis and treatment of vascular injuries, even in the solid organ injuries also. So how do we classify vascular injuries? There are a lot of classification in the scoring system, but none of them are a perfect system. But the most common one in classification of vascular injury is the American Association for Surgery of Trauma Organ Injury scaling system. And this scaling system is widely used grading system for traumatic injuries, and it is really well validated to predict the outcome, plus also the need for intervention, especially in solid organ injuries. And the other scoring mechanism is a mangled extremity severity score, or the MES score. And the key variable in MES score is the presence of vascular injury and limb ischemia, and this is really used in predicting the need for extremity amputation. So what are the factors that influence the natural history of vascular injury? So the factors, the main factor is an advancement in the pre-hospital care and a decreased transportation time to take the patient to the OR. These two are the main factors which are mentioned in the Western setup. But in our setup, pre-hospital care is not that much advanced. Even hospital care is also in question in our setup. But in the Western setup, these two factors are the main factor which affect the natural history of vascular injury. Beside this, the damage control techniques, including a shorter time of surgery, application of endovascular techniques, balanced resuscitation in the temporary intravascular shunt by itself also affects the outcome of vascular injury. So in pre-hospital management, there are two key components. The first one is stopping the bleeding, and the second one is replacing or the lost blood. So in mitigating a blood loss with appropriate volume replacement, the ideal one is a blood and the blood products. So where does bleeding comes? And there are three distinct pseudo-anatomic zones. These pseudo-anatomic zones, they are distinct and they are useful for management purpose. And these three are, the first one is the extremity hemorrhage, and the second one is the junctional hemorrhage. This includes hemorrhage that occurs in the groin, axilla, or neck. And the third one is the non-compressible torso hemorrhage. This includes the chest, the abdomen, and the pelvis. So we'll see each of the key components in pre-hospital care as compared to the pseudo-anatomical zone. So we'll see the stopping of the blood in the extremity hemorrhage. So in principle, we use a stepwise approach, and we use the hemostatic ladder. So in this hemostatic ladder, it starts in simple dressing, and if the blood is not controlled using simple dressing, we'll continue to apply pressure and elevate the extremity. And in the Western setups, there are ready-made topical hemostatic agents. So beside pressure and elevation, we might use topical hemostasis. And if all the three things are not controlling the blood, bleeding will continue in application of tourniquet. But there are exceptions where we might use tourniquet as early as possible. These conditions are either tactical situations or clinical situations. In the case of tactical situations, so in the presence when we are carrying a patient under fire, rather than going in this hemostatic ladder, starting from dressing, pressure application, topical hemostasis, rather we will just immediately apply tourniquet. And in the case of chemical, biological, radiation, or nuclear environment, in this environment, the three first tires of hemostatic ladders are not suitable. So in this case, we will immediately apply tourniquet. In the case of clinical situations, like if we see the state of the limb, so if a limb is a non-salvageable, mangled extremity, will not go through from dressing to pressure application to the topical hemostasis, rather immediately will apply tourniquet. And the other clinical situations which demand this application of tourniquet immediately is if a patient has a competing priorities, like if a patient has airway problem, we might rather than going in each of these hemostatic ladders, we will apply tourniquet. And in the case of mass casualty, where the number of patients outmatches the number of clinicians or MS, during this time we will use directly tourniquet. So in this picture, you can see that both limbs of the patients were tourniquet were applied, and in the left you can see that two tourniquets were applied. In the right extremity, one tourniquet is applied. So what are the principles in application of the tourniquet? So in the principle, so If a patient has a mangled extremity with bleeding, we'll apply a tourniquet, or if a patient has catastrophic hemorrhage, we will apply directly tourniquet. So unless a patient is involved in care under fire, or in the case of chemical, biological, radiologic, or nuclear environment, the application of tourniquet is 5 to 7.5 centimeter above the bleeding site directly, and we'll tighten the tourniquet until bleeding stops. But we need to know that there will be some oozing from bone in this. This will continue, but this is low pressure, and it is amenable for a pressure control. And if bleeding is not controlled, or if the tourniquet being applied for an above knee amputation, we might apply a second tourniquet proximal to the first one, and we need to note the time of application should be recorded. So when do we like to remove an arterial tourniquet? So we need to make sure that there is an alternative method for hemorrhage control before releasing a tourniquet. And the second thing that we need to check is releasing of the arterial tourniquet should only be undertaken in a controlled environment where a careful assessment and a rapid treatment is possible in the presence of deterioration of the patient. So we will not quickly remove tourniquet. Rather, what we do is we merely loosen it, and we'll see the response. And if we loosen it by after application of alternative hemorrhage control, when we loosen it, if the alternative method of hemorrhage controls are not successful, we need to retighten the tourniquet. So how do we stop bleeding in the junctional hemorrhage? Principle wise, it is similar with the extremity tourniquet. With a hemostatic ladder, but the only difference is this area is not amenable for application of tourniquet. The reason behind one, this site is not possible to get a proximal control beyond the wound, and the other is especially this the possibility of getting proximal to the wound is affected, especially in the case of axilla and groin, and there might be ischemic zone distal to the tourniquet might not be feasible. Especially in the case of neck, there might be ischemic zone distal to the tourniquet, so tourniquet is not feasible in the neck. And but the one thing that we need to know is this area is easily accessible and it is potentially compressible. So in the case of axilla and groin, we will follow the hemostatic ladder, like that's using dressing, then using pressure, then if available, we will use the hemostatic agent, but tourniquet is not an option in this area. In the neck, there are three presentation in the vascular injury that occurs in the neck. Patient might have visible catastrophic external bleeding, or patient might have a contained hemorrhage, and this contained hemorrhage may lead to development of hematoma, and this hematoma might compress the airway, resulting in a life-threatening airway obstruction, or patient might be presented with dissection of the neck vessels, and this dissection will result in neurologic sequelae, and this sequelae might range from subtle finding to a profound stroke might be present. So how do we manage if there is external catastrophic hemorrhage? The first one is the application of direct pressure with or without hemostatic dressing. This is approach of choice, but even the application of pressure by itself also affects the airway, and if possible, securing the airway in this setup is also considered. The other option might be a Foley catheter balloon tamponade, and what we do is we'll insert the Foley catheter into the wound, and we'll inflate the balloon with 10 to 50 ml. So in this picture, you can see that there is bleeding on subclavian artery, and the personnel is applying a pressure, but that pressure might not be adequate enough. So we might apply a Foley catheter. We insert the tip of the Foley catheter and we'll inflate it to about 10 to 15 ml, and this will cover the area. In the presence of contained hematoma, it is difficult to pick the presence of contained hematoma. So we need to have a high index of some suspicion. So what are the potential indicator for the presence of contained hemorrhage? One is when a patient has a wound which is deep to the platysma, when a patient presented with hoarseness of voice, in the presence of expanding hematoma or pulsatile mass and stridor. So in the presence of these things, especially in the presence of expanding hematoma, pulsatile mass and stridor, patient definitely requires a control of the airway. In the third presentation, like the basal dissection, there is nothing we'll do in pre-hospital management of this basal dissection. It is limited. There are also a complex or novel options in the stopping of the bleeding in the junctional hemorrhage. These complex or novel options either relies on a local effect or it might relies on gaining proximal control of bleeding. So those which methods rely on local effect, these are hemostatic agents like it is like a syringe, and we use injection of this chitosan soaked cellulose sponge into the axillary or groin wound, and this cellulose sponges will help us as hemostatic agent. The other is junctional tourniquet. These are novel options. These are a binder, plus they do have an inflatable balloon, and this inflatable balloon will be applied at the junction, and they are useful as junctional tourniquet. The other methods is gaining of a proximal control, and these are very complex things. This includes like resuscitative thoracotomy, so emergency thoracotomy, opening of the chest will be done, and cross-clamping of the descending aorta will be done, and this will be done only in the presence of a traumatic cardiac arrest. And the other novel option is application of endovascular balloon. This is called the resuscitative endovascular balloon occlusion of the aorta, or RIBOA. This is still not available in our setup, but in the Western setup, they'll use to control bleeding in the junctional hemorrhage. In the case of non-compressible torso hemorrhage, this is the most greatest challenge that physicians are encountered, and controlling bleeding in this torso area is very difficult. So some of the options are resuscitative thoracotomy, RIBOA, which is resuscitative endovascular balloon occlusion of the aorta. In some cases, in the case of abdominal injury, there are centers that uses gas insufflation or self-expanding foam in the abdominal cavity, and the other is pelvic circumferential compression devices. The only thing that we can apply in our setup easier is pelvic compression, circumferential compression device. This we can use bed sheets easily in our setup. Otherwise, the rest like gas insufflation or RIBOA, even the resuscitative thoracotomy, as technically might be difficult in our setup, but application of pelvic binder is not much difficult in our setup. We can use bed sheet. So there are criteria, and if these all criteria are met, we don't need to apply pelvic binder. Like if a patient's glaucoma scale is greater than 13, if the patient doesn't have any shock, and if the patient doesn't have any distracting injury and no pain on clinical examination of the pelvis, such patient doesn't need the application of binder. So once we stop the bleeding, we need to replace the lost volume. And there are resuscitation strategies, and these strategies are mainly used to minimize the lethal triads. These lethal triads are acidosis, hypothermia, and coagulopathy. So previous thought was the application of permissive hypotension. This is a paper written by Conan during the Second World War, and he says like injection of a fluid that will increase blood pressure carrier carries a danger in itself, and hemorrhage in the case of shock may not occur to a large degree because the blood pressure is too low and the flow is too scant to overcome the obstacle offered by a clot. But when we raise the blood pressure by pumping with the blood before the surgeon controls it, this will result in significant bleeding, and that bleeding will be grave for patients. So because of this, starting from World War II, permissive hypertension was considered as best strategy for resuscitation. But currently there is a novel hybrid resuscitation. This novel hybrid resuscitation was considered because this prolonged hypotensive resuscitation has deleterious effects. So because of this, the current recommendation is a novel hybrid resuscitation. So what are these novel hybrid resuscitation? So there will be an initial period of an hour with hypotensive resuscitation target, then it is followed by a normotensive resuscitation. We will initially make the patient hypotensive for about an hour. Then after, we'll make the resuscitation to a normotensive level. So the initial hour, this will allow time for clot formation and stabilization prior to challenging the patient to an increased pressure. So the initial 1 hour will be hypotensive, and this will help us to create the patient to create a clot, and this will hamper the bleeding. Then after, we'll return the patient to a normotensive level. We return the patient to normotensive level to ensure an improved perfusion and oxygen delivery of organs. So this will reverse the negative effect of permissive hypotension. So what is our blood pressure target? So the BP target is 100 millimeter of mercury, and during the permissive hypotension, the blood pressure should not be less than 90 millimeter of mercury, and during our normotensive resuscitation, the blood pressure should not be more than 110 millimeter of mercury. So the meeting a target of 100 millimeter of mercury is good in this setup. So this current resuscitation strategy is a novel hybrid resuscitation. So we'll keep the patient on hypotensive resuscitation target of not less than 90 millimeter of mercury for about an hour, and will increase to a normotensive one after 1 hour. So this 1 hour will give time for clot formation. Then by the time the patient reach to the normotensive resuscitation level, the peripheral circulation will be good. So what are the choice of the fluid? So we are saying that we need to resuscitate the patient. So what are the choice of the fluid? So it is clear that patients who are bleeding should receive blood as a replacement. But in the pre-hospital period, it might be difficult in transfusing the patient. So the balanced transfusion of packed RBC, plasma, and platelet in a 1:1 ratio is standard. But in pre-hospital period, because of difficulty of getting this blood products in the blood, crystalloid-based resuscitation will be applied in pre-hospital. But in the hospital management, the balanced transfusion of this packed RBC, plasma, and the platelet should be done. So whenever we are administrating any type of fluid, whether it is a crystalloid or blood, the blood should be warm. We say that one of the deadly triad is hypothermia. So to avoid the hypothermia, we need to warm any fluid to a body temperature level. So whenever possible, we use blood products. But one thing that we need to know is whether we use a blood product or a crystalloid-based resuscitation, our endpoint is similar. So we need to keep the patient in a hypotensive state for just only for 1 hour, for an hour. Then we need to keep the patient in a normal tensive period for subsequent time. Beside the these crystalloids or balanced transfusion, there are also pharmacological agents which are used during this resuscitation. One is TXA or tranexamic acid, and this is highly useful in decreasing the tendency of bleeding, and also the addition of calcium. I mean, as you know, that calcium is a main component in coagulation cascade. So we need to supplement the patient with calcium during this resuscitation. So once the pre-hospital period, like we said, that there are two key components. One is stopping the bleeding, and the other is replacing the lost fluid during the pre-hospital. Those things are also being done during the hospital period. So once we done those things in hospital, what we will continue is what we call the damage control resuscitation. And this damage control resuscitation is defined as a systematical approach to a major trauma, and it combines the CABC paradigm with a series of clinical techniques which point to wounding to definitive treatment in order to minimize the blood loss, plus in order to maximize the tissue oxygenation, and finally to optimize the outcome. So whenever we say the damage control resuscitation, we need to know that this damage control resuscitation also includes damage control surgery, and the damage control surgery is the operative strategy of damage control resuscitation. And this damage control surgery, it sacrifices the completeness of the surgical repair so that the patient will get time to attain its physiological state from the injury. So in the emergency department reception, so we use the CABC framework, and this CABC framework allows us to identify and prioritize the immediate steps in stabilizing and managing the patient. So the C stands for a catastrophic hemorrhage control. So we say that in pre-hospital, if the setup are lost, patient might have a tourniquet or external dressing. Or in the best setup, patient might have resuscitative endovascular balloon occlusion of the aorta. So once a patient comes into the emergency department, we will check those techniques which are used to control the bleeding. So in the case of tourniquet, we'll check the position and the adequacy. So we might need to tighten the tourniquet, or we might require to add another tourniquet based on the adequacy of the tourniquet. And we'll consider judicious release if the wound pattern suggests application of the tourniquet is not required. This will be done after a primary survey and after we stabilize the physiology of the patient. So if patient comes with external dressing, we might do appropriate packing, and plus if we have hemostatic agents, we might consider to add hemostatic agents besides packing. And if a patient come with resuscitative endovascular balloon occlusion, we need to know the time of balloon deflation based on the primary time of balloon inflation. So the rest, I think, is not the main topic of discussion today. So after this control of the catastrophic hemorrhage in emergency department, we will continue the routine A, B, C, D, E parts. So you know that the A stands for the airway plus the C spine protection, and B stands for breathing. In this time, we will optimize the gas exchange, and in C, we'll focus on the volume resuscitation. And so in the C, it is a process of achieving hemostasis that we did previously with application of tourniquet or dressing or other mechanism. Plus, we will add also volume resuscitation, and these things will be done simultaneously. So during a resuscitation phase, we'll put two large bore peripheral lines, and these large bore peripheral lines offer the greatest flow rate with 14 to 16 French gauge are commonly recommended. On D, we'll check for disability, and on E, we'll expose the patient, and this also includes a transfer of the patient. So how do you diagnose vascular injury? So this issue of diagnosis of vascular injury is raised because vascular trauma presentation has a scope from a life-threatening hemorrhage secondary to major torso or extremity vascular disruption to undetectable signs in occult injury. So the extent is from overt hemorrhage to undetectable signs. So for those with overt bleeding, it will be easier, and we know that the patient has a vascular injury, and without doing any workup, we'll go for directly to the OR. But for the patient might also have a vascular injury, but it might be difficult to detect any signs. So for those non-detectable signs in occult injuries, we'll rely on our physical examination. So on history, we need to check for mechanism of injury. So the presence of significant blunt injury. So for the presence of significant blunt forces across major vessels or penetrating injury around the major vessels might be an indication for the presence of vascular injury. Plus on history, we'll check the blood loss at the scene. So we'll check the history of a pulsatile bleeding from the wound, a significant blood at the scene or on the clothes of the patient. So we'll check on those things. And on physical examination, we'll check for bleeding indicators. So if a patient has pre-hospital hypotension, that might be a sign for the presence of major vessel injury. Or if a patient has shock, which is unexplained with non-bleeding extremity or neck laceration, this is also an indicator for these are checked from physical examination on pre-hospital, and on hospital physical examination, we will check for the presence of pulsatile bleeding, extremity pulses will be checked, also the absence of pulses, or in Doppler signals if there is absent signals, or we might consider injured limb with an injured limb, and if the injured index extremity index is less than 0.9, this also shows that there is injury, and the presence of bruit or trill over the injury site, and the presence of peripheral nerve deficit is also might be physical sign. There are also hard and soft signs that we pick during physical examination. So the hard signs include a pulsatile hemorrhage, expanding hematoma, bruits or thrill over the area of injury, absent extremity pulse or injured extremity index less than 0.9. These are hard signs which are if a patient has these hard signs, so rather than going for other investigative modality, we will rush to the OR and we will explore the patient. The soft signs includes the presence of or the presence of history of hemorrhage at the site, wound over the neck or extremity, and if a patient has unexplained hemorrhagic shock, and the presence of neurologic deficit, and the presence of high risk high risk the presence of high risk fracture, dislocation, or penetrating injuries. Proximity to the wounds also are considered as a soft sign. One thing to mention here is the presence of fracture or dislocation. That's based on the site, we'll think of the possible injured artery. So the presence of cervical spine fracture might suggest the presence of vertebral artery injury. Thoracic spine fracture may be a sign for thoracic aortic injury. A presence of supracondylar humerus fracture might show us the presence of brachial artery injury. The dislocation may result in popliteal artery injury, and tibial plateau fracture. Patient might have a calf compartment syndrome. So how do definitely diagnose a patient with a vascular injury? So the definitive diagnosis, one, if a patient has a hard sign, so we will directly go for surgical exploration, and by surgical exploration, we will know that the presence of vascular injury. We will directly examine the vessels and we will know that the patient is having vascular injury or not. The others, if a patient has soft sign in the other, we will continue doing investigation. So this investigation includes an emergency center or intraoperative angiography, or a multi-detector CT angiography, or a formal catheter angiography might be the option. Regarding Doppler ultrasound, in our setup, we will use it for diagnosis purpose in the vascular injury, but because of operator dependency, plus it takes a time. So in the Western setup, they are not using Doppler ultrasound for a definitive diagnosis of vascular injury. The other drawback in the ultrasound is because of the wounds in extremity in the other side. It is difficult for the probe to explore each part of the vessel. So how do we clear a patient who is suspected to have vascular injury? So based on the site of injury, we can clear trauma patient from the presence of vascular injury. So in the case of head and neck injuries, if a patient is alert and hemodynamically stable in the absence of a high risk mechanism, and a normal neurologic examination, plus a negative physical examination of the head and the neck, plus the absence of cervical spine or basilar skull fractures, we can surely rule out the presence of vascular injury around the neck and the head. In the case of chest and the abdomen, the normal chest and abdominal examination, both on physical examination and on X-ray evaluation, plus a negative past, plus the absence of high risk mechanism, can rule out the presence of chest and abdomen injury. In the case of extremities, the patient is alert, hemodynamically stable, with normal neurovascular examination, plus an absence of significant hematoma or hemorrhage on the extremity, plus absence of neurologic deficit in distal part of the extremity, plus if the injured index in extremity index is greater than or equal to 0.9, we can surely exclude the presence of extremity vascular injury. So what are the types of vascular trauma? We can classify vascular pathology classification can be classified as 5 types. The first one is intimal injury. This intimal injury might include the intimal flaps or intimal disruption, or it might also result in subintimal or intramural hematomas, or patient might have a complete wall defect, and this complete wall defect will result in hemorrhage if there is no surrounding coverage, or if there is coverage, it will result in pseudoaneurysm, or patient might have a complete transection of the vessel, and this also will result in either hemorrhage or occlusion with thrombus. The other is if the injury might result in arteriovenous fistula-like communication between the artery and the nearby veins might occur. And the fifth type of vascular trauma is spasm, and this spasm is most common in young patients. So what is the natural history of these types of vascular injury? Based on their type, they do have their own natural history and complications. So those penetrating mechanism of injuries will result commonly laceration, contusion, or arteriovenous fistulas. So in the laceration, it either results in, if left untreated, it might result in pseudoaneurysm or thrombosis. And if this is not really treated, the complications like ischemia, rupture, or embolization will occur as a complication. The case of contusion, if it is not treated initially, it will result in stenosis or thrombosis at the site, and this also results in ischemia, distal ischemia, or embolization. The AV fistulas, this will, the natural history, if it is left untreated, there will be an increase in size and flow, especially more on the venous side, and this will result in Steele syndrome, and patient might have also a high output heart failure might be occurring if it is left untreated. In the case of blunt mechanism of trauma, what might happen on the vessels is there might be intimal dissection, thrombosis, and if this intimal dissection is less than 25%, there might be a possibility of spontaneous resolution, and it will not progress to anything. But if the intimal disruption is more than 25%, patient might end up in having pseudoaneurysm or thrombosis, and this might be complicated with rupture or ischemia. And the other is pseudoaneurysm, thrombosis, AV fistulas, and transactions might occur during blunt vascular trauma, resulting in those natural histories and complications. So what is the general operative principles? Talking the details principles, the detail operative principles might be difficult in this setup, but we'll mention just only the general operative principles. And so this includes the initial exposure and control. So the bleeding has stopped by mechanisms like tourniquet or wound dressing or pressure. So what we'll do is initially we need to obtain proximal and distal control. So we need to go proximal to the wound and control the vessel. Plus we need to go distal to the wound and control the vessel. And this controlling mechanism, proximal and distal controls, commonly are done by open vascular procedures. But in the Western setup, and also in difficulty of opening the proximal and distal site, angiographic balloon controlling system might be considered. So once we exposed and controlled all the proximal and distal part, what we will do is we will assess the injury site, plus we will also assess the patient's status. So our selection of vascular repair the technique is dependent on one intraoperative finding, the other is the patient's physiology, intraoperative physiology, and the third is the institutional capacity. This institutional capacity is a gadget plus the personnel will also affect our selection of vascular repair. So what are the definitive managements? These definitive managements depends on different factors, but majorly we can classify them as a simple and complex vascular repair techniques. So the first three are considered as a simple vascular repair techniques, like simple lateral repair. Ligation is also considered as a repair technique, plus application of a temporary shunt insertion. So in this picture, you can see that there is a energy tube in the wound. So we can use either energy tube or an IV set to shunt the blood flow for temporary. So these three, the first three are considered as a simple vascular repair techniques. The patch angioplasty in between the anastomosis, graft interposition, endovascular grafts, and angiographic embolizations are considered as a complex vascular repairs. And those complex vascular repairs are only done when the patient physiology allows us, plus when the institution's capability allows us. So these are the definitive management, and thank you. And I'll give the podium for questions and answer. Thank you.
Okay, thank you very much, Dr. Tizazu. It was an amazing and elaborated presentation. Thank you very much. So, participants, if you have any questions regarding today's topic, you can write down your questions in the chat box, so doctor will be addressing them. Okay, there's one question by Tamasgan Getachew. What are
Okay,
the yeah.
Okay, I've seen it. Yeah, what are the golden hour for repair of vascular injury and risk of gangrene after tourniquet? Okay, I think it would be nice to answer both questions together. So regarding the golden hour for repair of vascular injury, previously it was taught that 6 hours is considered as a golden hour for repair of vascular injury, but it depends based on the injured vessel. It depends on the injured vessel. So there are vessels which gives us additional times, like there are vessels which have more collaterals. So the either ligation or injury of that vessels might give us more time. For example, if we see a brachial artery injury, so unlike those popliteal or and other vascular injury, brachial artery injury repair can be done even in days, like 48 hours, 72 hours, even more than 5 days. Also, I've seen a patient with ligated or injured brachial artery, and the repair was done like more than 5 days. So we might not have an absolute golden hour in each of the puzzle. So if we see like popliteal artery, that will not give them even a 6 hours. So popliteal artery, especially in the presence of hypotension, it is below 3 hours. So it is difficult to put a golden hour for every puzzle or an absolute 1 hour for golden hour. So it depends based on the vessel. So there are also vessels which are ligatable, like deep profunda artery can be ligated. In internal iliac artery might be ligated without any complication. Those might not need any repair. So I cannot give you a golden hour, an absolute golden hour. And the other question is risk of gangrene in application of tourniquet. Yeah, there is a risk of gangrene while we are applying a tourniquet. That's why a hemostatic ladder should be maintained. So we need to start initially with wound dressing, if not a pressure application and elevation. So this wound dressing and pressure application will allow the collaterals to flow distally. But in the case of tourniquet, so what would happen is all the collateral flow to the distal extremity will be nil. So this will result in gangrene, but this will be minimized if the patient gets early reconstruction and early management. So we use tourniquet for a transportation purpose, and it should be in especially not more than 6 hours in when we apply a tourniquet. Especially if a patient is in shock, it should be even less than 3 hours. But by applying a tourniquet, we will risk the gangrene of the extremity, but we will save the life of the patient rather than allowing the patient to bleed a lot. It might be good to apply tourniquet and save the life at the risk of the limb. But we need to follow the uh, hemostatic ladder. So we'll not apply tourniquet right and left because it affects collateral perfusion. So could you please summarize on fluid resuscitation part? So on resuscitation, that what I mentioned is there are two strategies. The first strategy is the permissive hypotension strategy, and the newer one is the novel hybrid resuscitation. So the first one, the permissive hypotension, is we don't want the patient to have a high blood pressure. The reason behind is if we pump a lot of fluid, maybe in bed setup blood, and if we get a high pressure before controlling the site of bleeding, if we give a patient or if we pump the patient, so bleeding is controlled by the clot. So when we increase the pressure, there will be dislodgement of the clot and will further exacerbate the bleeding. So that's why we need to maintain the hypotensive level. But if we maintain this permissive hypotensive level for a long time, it also has effect on tissue perfusion. So we don't want to keep those things for a long time. So just giving the patient blood if possible, if not a crystallers, just to maintain a hypotensive level for just an hour, so that will give the clot formation a time. So once a clot is formed, we might give the patient a normal tensive resuscitation period. So I think that might summarize fluid resuscitation part. So whenever possible for a trauma patient, better to use blood and the blood products. But I know that that might be difficult in a lot of our centers. So in that setup, we will use crystallers. But in the best setup, it should be given in 1:1:1 ratio. That's a packed RBC with a plasma and a platelet. How far should the tourniquet be from the bleeding site? It should be 5 to 7.5 centimeter proximal to the bleeding site. And the tourniquet duration, like I said, we cannot uh, apply the tourniquet for a long time. This will result in loss of the limb. So we'll follow the hemostatic ladder. We'll apply the dressing. Then, if it is not controlled with dressing, we'll continue application of pressure on the wound site and we'll elevate the extremity. If it is not adequate in our setup, we don't have the hemostatic agent, so we'll continue to apply tourniquet. But that should be in a very low time so that the patient will get to the nearby center for management. Otherwise, if we are going to keep it for 24 hours and more, obviously we know that the patient will lose the limb. So I cannot give you the exact duration, but we use tourniquet just to transport the patient to a nearby health facility until vascular reconstruction or rather than this in our setup, rather than applying a tourniquet for a long time, it might be better to go and ligate the injured vessel, because the other collaterals will give time for the limb, and you'll send the patient for vascular surgeon, and the vascular surgeon will manage the ligated vessel. But if you apply tourniquet for long time, you are also affecting the collateral flow. Can we get the PPT? Yes, I will give it to the Blue Health team, and I think they will give you the PPT. What is the advantage of CT angio over MRA? And you know that MRA will take long time and MRA is not used in trauma setup. Plus the time which takes for CT angio to cover all the vessels is less than 2 minutes. But for MRA, it takes a very long time. So MRA has no place in trauma serious or in trauma diagnosis time. Any missed question, maybe?
No, everything was addressed, doctor. Yeah. So thank you very much. So on behalf of Players Ethiopia and all our participants, we would love to thank you for taking the time to present on our platform. It was a very nice presentation, and we hope to have you in future sessions with related and different topics as well. So if you have any last remarks that you want to add, let me give you the stage one more time and we can end the session.
I think thank you for all your participation, and regarding vascular injury, you know that it is high. It has high mortality and high morbidity, and early management and early referral to either vascular surgeon or in a setup where these things will be managed will save the life of the patient and maybe the limb of the patient. So based on this hemostatic ladder, please use those things in your health setup and transfer the patient as early as possible to either salvage the limb or at least to salvage the life of the patient. Thank you.
Okay, thank you very much, Dr. Tizazu. Have a good night.
Thank you. Have a good night. Okay.